Dr. Elly Odongo. He's a gynecological oncologist, and he's a retired president. Him, Uhuru, and others. Same was up. He's President Emeritus of the Kenya Obstetrical and Gynaecological Society.
Well done.
It's worked, huh?
Hey, Eric.
I didn't think about it. The Kenya Obstetrical and
Now you
Gynaecological.
see.
Yeah. Welcome to the hot seat of the Situation Room, Dr. Ali. We call this the Situation Room. Today, every Friday, we have a Health Friday conversation. And this month of January, these 2 months of January, the Cervical Cancer Awareness Month, right?
Yes.
You are a gynecological oncologist. That means that you know very many things. That people say, I know a thing or two. No. You know 1,000 things or 2,000 things about this particular conversation. Karibu sana. CT has been sponsored by EcoBank this week to go across Africa to pick several proverbs from one African country and bringing them to us. Okay. So this week he's been in the Kingdom of Morocco. Mm-hmm. And today's proverb, CT?
Today is our last day of these proverbs from Morocco. Simple, straightforward proverb. Lies have no legs.
Lies have no legs. Dr. Ari, what's your interpretation of it?
Well, that could mean that once a lie is told, it can spread without having to be propped up with the legs or something like that.
So how does it spread? It's airborne.
But when I just said lies have wings.
Maybe it has wings or it's airborne. Yeah, that's what I understand from that.
Okay. One interpretation.
It's a very interesting interpretation indeed.
Yes. One interpretation. Thank you very much, Dr. Ari. So, cervical cancer is a major disease in this country.
That's right.
But many people do not understand what exactly cervical cancer is. So because this is the Cervical Cancer Awareness Month, let's begin the awareness by just defining what is cervical cancer.
Yeah, first, thank you for having me here. I try to break it down to what we can understand, not to sound like I'm in a medical school. So we have to first understand what organ we are referring to. Mm-hmm. So the cervix is part of the uterus. The uterus usually has two parts. We have the body and the lower portion, which is the cervix. So the body is where, of course, the pregnancy, which carries the pregnancy, and the cervix is what you feel when a woman is in labor. You hear terms like 5 centimeters dilated. That's the part that opens up. So it's the lowermost portion. Okay. So cervix just means neck. So in other words, it's the neck of the womb, so to speak. You don't usually see it. It's invisible because it is recessed deep inside the reproductive tract, and you can only see it when you do an examination with an instrument. An instrument we call a speculum. A speculum is an instrument that opens up like the beak of a bird. Mm-hmm. You insert it into the reproductive tract, you open it up, and what you encounter is usually the cervix. So the conditions that affect that, what I've just described, is what is called the cancer of the cervix, so the cancer that affects what I've just described. Mm-hmm. And cancer just means a malignant condition. By malignant, I mean it has ability to spread to other areas of the body and ability to invade and spread to other areas of the body. So having defined that, cervical cancer is a common cause, of one of the major causes of deaths among women, not only in the reproductive age, but beyond the reproductive age. The statistics that I can give, maybe I may just give the statistics in this country. We approximately around 6,000 new diagnosis of cervical cancer in a year. And out of these, half, probably around 3,200 deaths arising from cervical cancer. So therefore, we need to bring a lot of awareness and more so talking about the risk factors and how this disease can be prevented and managed.
So, yeah, it's also called the silent killer. And just again, looking at those numbers, it's the second most prevalent or second most dangerous cancer for women in Kenya and maybe in parts of the world. Why is it the silent killer? Why?
Well, I wouldn't say there's only cervix that is a silent killer. As a gynecological oncologist, quite a number of the malignancies or cancers that affect the reproductive tract are actually silent. So I don't want to really digress much, but just to mention cancers like of the ovary is also a silent killer. Many times you find it late. Cancers of the uterus also the same, only that uterus has a bit of propensity of being found earlier because of the abnormal bleeding. But the cancer of the cervix, by the time you are seeing the symptoms, which maybe we may describe later, the disease has actually spread, and that is why we are seeing a lot of deaths arising from the condition.
What about the pain factor? I ask this because a lot of patients with cervical cancer speak of the fact that they felt no pain, they felt no discomfort until something else happened much later. Is that also contributing to why it's silent, because you don't feel anything?
Yes, most of the time you don't feel anything, and by the time you start exhibiting the symptoms, then the disease has spread. But I also just want to tie this together with the common presentation of cervical cancer, which many women don't report because of embarrassment or sociocultural issues. For example, one of the commonest presentation is what we call postcoital bleeding. Postcoital bleeding means bleeding after sexual contact, and many people don't report this. The other common symptomatology or presenting symptom is abnormal vaginal discharge, which is usually watery at some point. Then it becomes kind of foul smelling and kind of stigmatizing. So they tend to keep it for long, and by the time it causes them concern to the extent that they want to seek help, then it means that the disease has spread to
and what stage are we looking at by the time those particular symptoms then are? What stages are we looking at?
Yeah, it's difficult to determine stage just from symptoms.
Okay.
Yeah, because cervical cancer staging is a clinical stage. It's clinically staged. But now we have got revisions on how cervical cancer can be staged, in that you can also use imaging studies, including PET scan, to allow you to come up with a proper staging. However, by the time one has those symptoms, there is almost always a lesion on the cervix.
Okay.
Yeah. So when you do a speculum, what I described earlier, you'll almost always see a lesion on the cervix. And by the time you are seeing a lesion on the cervix, we are talking about at least a stage 1B. Maybe if time allows, we may go through the stages. But just to reiterate that by the time you are seeing those symptoms, there is almost always a lesion on the cervix.
So, I mean, I'm sure we'll go into prevention. What are some of the things that have been talked about that? We'll talk about the HPV vaccine and all. But pap smear has been touted and keeps being drummed in our ears. You know, have your pap smear every 2 years. How effective is a pap smear in being able to tell the general health of the cervix?
Yeah, pap smear has been with us for many years, and thanks to Dr. Papanicolaou who brought this to us in terms of that it's a test that can be used for screening for cervical cancer. So pap smear is a screening test. I know you said it's been drummed in our ears, But I think it's mainly in certain women of certain socioeconomic status and level of education and knowledge, because from the data we have is that pap smear is not as prevalent as we tend to read in other parts of the world. It has been very effective in detecting early changes on the cervix. Let me correct this. Pap smear is not used to diagnose to make a diagnosis of cervical cancer. It's a screening test for asymptomatic individuals. That is, you are screening women who have
general health of the cervix, the area.
Yes, no lesion at all. Because by the time a woman is presenting with the signs and symptoms I described, pap is of little use.
Okay.
Because of two things. One, it may actually miss invasive disease. By invasive disease, pap can miss obvious cancer by up to 50% of the time. Because many times we've seen women who have come to us, they say, I've been going through pap smear, I've been bleeding actually, and pap smear was done and it was normal. So this is just to reiterate that pap is a screening test for asymptomatic individuals. Once those symptoms start developing, pap is not indicated under such situations.
But then, Dr. So if you are doing the regular screening via pap smear, what do they say? Twice a year? Every 6 months?
Every 2 years.
Every 2 years.
Yeah,
So-
there has been changes in algorithms of screening with pap, but of course the general recommendation is yearly pap.
Okay. So annually, you go for the pap smear.
Yeah.
And you're saying at that point you're asymptomatic.
Yeah.
When you start developing symptoms early, this pap will not detect it.
It will not. But once you start having postcoital bleeding because of the tumor or this abnormal vaginal discharge, foul smell, pap may detect, but it may miss it in 50% of the time.
Okay.
So
is there any instance when pap smear detects an area of concern that could be a cause for which could lead to a cervical cancer?
yes, maybe
diagnosis?
I'll dedicate a bit of time on the pap.
Okay.
Yeah. So once a pap smear is done, the pathologist gives an interpretation of what he sees. Pathologists, let me put it cytologists, because they're kind of looking at the appearance of cells. And it can either be 4 possible outcomes when you're looking at the pap report. One, it could be nothing, in that negative.
Looks normal.
It looks normal.
Okay.
Secondly, it could be that you have abnormalities of certain type of cells. We call them squamous cells, which are lining that line the cervix. And even in the squamous cells, the pap can also report a little bit more possibilities. Either the cells are looking abnormal, or they are moderately abnormal. I'm trying to simplify it, or severely abnormal. Sometimes, so when you look at a pap, you see reports like a typical squamous cells, which means the cells are just atypical, or low-grade squamous lesion, or high-grade squamous lesion. Then the pap can also report cells that line the inner part of the cervix. We call them the glandular cells. Or can also report that these cells are so abnormal, it is favoring cancer. So once you look at the pap and you see that there's nothing, or the cells are just atypical, those women should just be followed up. But if you start seeing that the cells are looking really abnormal, then the women are advised to go to a further step of screening.
Okay.
And we call that one colposcopy.
Okay.
So an abnormal pap is the entry point towards what we call colposcopy.
Okay.
Colposcopy means examining the cervix under a magnification. So, when you're doing a pap, you're just using the naked eye. But once the pap shows some abnormalities, then the woman should undergo what we call a colposcopy. You examine the cervix under a magnification.
Mm-hmm.
And when you are doing this, you apply some acetic acid. Acetic acid is vinegar, what we use mainly on our tables. Mm-hmm. And when you do that, and there are some color changes that may suggest that there are abnormalities on the cervix.
So still on the pap, just a little bit, like you said, certain women in certain socioeconomic class then would be able to go in for a yearly pap. I mean, we do.
That's right.
Right? But just looking at the numbers, for you to confirm that the majority of women who are affected by cervical cancer today are also in the majority when it comes to those who do not get a pap smear.
That's right.
And most often it is because of the affordability of the screening.
Yeah.
How do we handle that?
Yeah, all this has been looked at, and we should align ourselves to the World Health Organization prevention strategy, the 1970-90 strategy. I don't want really to digress right now, but we have initiatives or modalities of how we can tailor the screening of women, especially in the low socioeconomic status, because they may not afford a pap, because pap is quite costly.
It is.
Because you have to see a gynecologist, the kit itself is costly, then there are those overheads of a cytologist to look at it. So there are initiatives or areas that the Ministry of Health has introduced. We call it a single visit approach and visual inspection of the cervix with acetic acid. This is, allow me just to explain a bit what this means. When the women come for checkup, you apply you do the general examination, you do what I talked about, the speculum, then you apply acetic acid onto the cervix. It's a very cheap screening modality. What happens is that when the cells are abnormal, which means that they are dividing rapidly, they tend to have a higher content of DNA or proteins. So when you apply the acetic acid, they kind of tend to clump and gives you an appearance of white staining on the cervix. So this is a method that has been used for screening in low socioeconomic settings. So just to address that issue of probably to that
Cost,
there's a cost towards screening of women. Now that we're talking about screening, the World Health Organization in the 1970-90 strategy recommends that women should undergo screening with a high performance or high fidelity test, and in this case should be a HPV DNA screening. Why do we recommend this? Because we now know that the HPV is the common cause, the most important cause of cervical cancer, more than 90% of cervical cancer. So HPV DNA is also gaining some traction in terms of screening for cervical cancer.
You basically described where the cervix is, and you said the womb has these two parts. There's the body and the cervix. Now, we've heard of many times when an operation has been conducted on the womb, hysterectomy, which removes the uterus. When a uterus has been removed, is there still a risk of cervical cancer?
It depends on the reason why the uterus was removed. The uterus can be removed because of many reasons. It could be that there was a problem in terms of maybe the heavy bleeding, or that could not be controlled by other means, or could have been removed because of cervical cancer. Now, if the uterus was removed because of a condition that's not related to cervical cancer or a pre-malignant means pre-cancer, then that kind of eliminates the risk of cervical cancer. However, if the uterus was removed because of pre-malignant condition, pre-malignant means pre-cancer, or due to cancer, then the risk is there of developing cancer. And in this case, it will not be called cervical cancer. I'm saying this because what causes cervical cancer is also responsible for cancer of the vagina and also responsible for cancer of the vulva. The vulva is that outer part of the female genital tract that you see when you look in the mirror. And so there is a theory known as the field theory, in that those who have cervical cancer, 10% of the time they could be having a related condition on the vagina or on the vulva, because the risk factor is still human papillomavirus. So if a hysterectomy was done because of cervical cancer or pre-cancer, then there's a risk of the same condition developing in the vagina, and therefore these women still need to go through the usual screening. In this case,
hysterectomy, what is it and why is it necessary?
Okay, hysterectomy, maybe we focus on in the scenario of cervical cancer.
Yes.
Okay. Yeah, hysterectomy means the removal of the uterus. And now that we are focusing on cervical cancer, in some scenarios or in some stages of cervical cancer are amenable to hysterectomy. Maybe let me just say that not all women should undergo hysterectomy because they have cervical cancer, because you have to tailor their needs. We are seeing younger women who have cervical cancer and they may still want to carry on with in the reproductive desires and motherhood and all that. And once you do a hysterectomy, that means you have brought an end to their obstetric career. So in this case, there are several management options that you can offer, in that you can actually remove only that part of the cervix that is involved by disease. And this procedure is what we call a trachelectomy. Remember, when you remove the part of the cervix, it also compromises the ability of the uterus to carry a pregnancy, in that there's a risk of preterm births and preterm labor. So when you're doing this kind of procedures, then you are advised or expected to put what we call a purse string, kind of a purse string on the neck of or where the cervix was, so as to hold the baby.
Kind of like a McDonald's stitch, what they call.
Yes,
the same
kind
idea.
It's same idea. McDonald's stitch or Shirodka stitch. It's same idea. Now, for those who desire the fertility and maybe the stages are not really advanced. And then hysterectomy for those who may not desire fertility and the stage is amenable to surgery, then you offer hysterectomy, which means removal of the uterus. And just to also inform the viewers that not all cervical cancers are amenable to surgery, because surgery can lead to more side effects or morbidity if done beyond a certain stage. Mainly because the purpose of surgery is to remove, you're able to go around the tumor and remove all of it. You don't want to cut through tumor. Because once you cut through tumor means that you are increasing the chances of recurrence amongst other complications. So beyond a certain stage, then we recommend chemotherapy and radiation, whereby chemotherapy is given just as an adjunct to radiation, but the mainstay of treatment for very advanced disease is radiation. So I could be digressing a bit.
No, it's still on track.
Oh, no, you're not digressing at all.
On track.
You're being comprehensive.
Yes, that's what it is. I want to ask about the HPV, the human papilloma virus. What is it? What are the risk factors for cervical cancer? And what's the association of HPV and sexual activity?
Yeah, human papilloma virus is a family of viruses. There are over 100 types of human papilloma virus, but those of importance to us are not so many, and those are what we call the high-risk types, because they have got the ability to enter into the cell and change the genetic makeup and convert it into a malignant disease. It is sexually transmitted, and it is very common in that the prevalence in East Africa is around 30%. The prevalence in Europe and other places is around 15%, which means that even a single sexual exposure is enough for one to acquire human papilloma virus. The concern is not really the acquisition of the virus, because most people who are immunocompetent, they clear the virus within 1 or 2 years. But sometimes the virus persists because of one reason or another. I may give examples, situations whereby the virus can persist. One is when there's reduced immunity, especially in our part of the world. We have got very high, not very high, but high prevalence of HIV. And HIV co-infection itself is kind of a promoter or a risk factor, in that these women who have HIV infected are not able to clear the virus. And that is why this explains that cervical cancer is more common in women of this population. However, immunosuppression or reduced immunity can also be due to women undergoing chemotherapy or those who have undergone organ transplant. Then that's the predisposes to persistence of the disease. And I want to insist that most still clear the disease, but the issue is usually persistence of disease. And there are also cofactors towards acquisition of human papilloma virus. Of course, we've already mentioned the issues around sexual activity, multiple sexual partners, or a high-risk partner. One can be monogamous but has a high-risk partner which predisposes them to acquiring the high-risk types. Then there are also cofactors like smoking, because then that impairs the ability of the body to clear the virus. Co-infection with other sexually transmitted infections. We have conditions like chlamydia. Dietary dietary concerns like deficiency of vitamin C and retinoids, amongst other deficiencies. And also there's been the concerns about contraceptive use, a little bit controversial. I wouldn't say the word controversial, but a lot of studies are being done around this area.
Inconclusive.
Let me call it inconclusive, because the postulation is that if I'm on a contraceptive method, then I may not need to use any barrier method, for example, and that one predisposes to acquisition of other high-risk types of human papilloma virus.
The vaccine then, the HPV vaccine.
The HPV vaccine has actually been approved for use. It was approved by the FDA. There are several types of HPV vaccine. Currently we have 3 in the market. We have one that covers against two high-risk types of HPV. And then there is another one that covers against, works against four types of HPV, and there is another one that 9 types, also known as the nanovalent vaccine. What we have in our program in Kenya is the one that acts against the 4 types of HPV. So the HPV vaccine is not a live vaccine. I mean a live particle. Actually, what is administered, they are called viral-like particles, which have been which mimics the HPV. So the immune system recognizes these particles and forms antibodies against the HPV, and this helps in clearing the disease. So the approval, of course, is for 9 to 26 years, but this has been extended to 45 years. So the FDA approval is up to 45 years.
So women up to the age of 45
yes,
can get the vaccine.
Can get the vaccine.
So how long, and this is interesting, because, I mean, sure, when the calls for getting girls between the age of 9 and 14, that's where it started. Those are the numbers that we saw. To then come out and get the vaccine, and you get one and then you get the booster. Of course, it went up in controversy, and everybody was saying, no, what we are doing is we're encouraging promiscuity amongst girls, etc. I mean, that's a whole social conversation. But when you talk about introducing viral-like particles that then form antibodies, how long do they remain in the system in order to protect one from getting the virus? Because a girl at the age of 9 and then going well into her productive years would need that kind of protection for a while, no?
And that is why we have the concept of repeat doses.
Okay.
In fact, the recommendation is to give it at different time points, at 0 months, 1, and 6 months. We are now seeing recommendations from elsewhere about a single dose vaccine, but we are still looking at the data, which needs to be validated before it becomes policy. Coming back to your question, how long does it last? The reason why it's given in younger, is recommended to start in younger women, is because they have not been exposed yet to the HPV, or most likely they haven't been exposed to HPV. And the level of antibodies that are produced after a single injection is quite high. It's measured in what we call the geometric mean titers. So the titers are very high, even after a repeat, and they can last for a lifetime. If it's given to older people, then the titers are a little bit lower, and that is why it's recommended that you give it in younger women.
Are they... Okay, I'm going to phrase this question. When we talk about cervical cancer and work around it, where have we had research conducted among populations, and what are the findings of any research that has been done in this field? Why I ask the question is, I'm leading to, is there a certain age that we find people are more likely to be susceptible to the disease, or do we find that there's an age group of women in certain communities who have shown a higher prevalence of cervical cancer? And what is it? Is it always the HPV virus, or are there other factors that contribute to this?
Yeah, we have a lot of research that has come in, both in from the other parts of the world and also local research. So I may not quote names here, but we have quite a number of papers and work that has been done in the AMPATH program in Western Kenya, in the HIV screening program, amongst other areas. And we are seeing the same pattern in that HPV infection, or let me put it this way, cervical cancer, in cervical cancer cases, and you look backwards and try to type the kind of virus that is responsible, it's actually type 16 and type 18. And the population dynamics is that those who have immunocompromised, especially mentioned HIV, you are seeing cases when they are much younger. The mean age of cervical cancer is actually what a couple of years ago it was around 51 years, 52 years. But now we are seeing numbers across the spectrum, so you can't really tell for now that this is the age that we have the majority of cases of cervical cancer. However, the reason why we are really recommending for screening and treatment of pre-cancer is that it has a very long latent phase. By long latent phase, I mean from infection to the time that the disease develops, it can be up to 10 years. Or even more, even 15 years from the first infection with HPV. So this gives us a lot of time to prevent the disease. If you don't catch it at if you don't prevent it at vaccination, you can get it within these 10 years by the screening we are talking about. And once you screen and find there's a pre-cancer, then there are management modalities that you can institute before it becomes cancer.
So, so this is one of the few cancers that you can actually point to and say, this is the thing that causes this cancer.
That's right.
Are we sure? Because the case for vaccination against something that is killing women after breast cancer at such a high rate is that you can point directly. Let me ask the question this way. For cases of cervical cancer, when you look and say what has caused it, as you say, you will find HPV 16 or 18.
Yeah.
Unequivocally, in each case, will you be able to point the cause of this cervical cancer to an HPV and say it is the cause? You will.
You can.
Okay.
And you will. Yeah, it is. And we've done it. Yeah, we've taken tissues and worked backwards and see what is responsible for this cancer. And more often than not, you find the high-risk types, 16 and 18 in that population.
So then the vaccines that are available, which we are giving to our girls from 9 and above, then you say they cover 4 high risk. And those are...
Actually, the 4 covers 6, 11, 16, and 18.
Okay.
6 and 11 are what's responsible for what we call the genital warts. They're not high risk. Genital warts are like bumps on the skin, and the risk factors of acquiring genital warts are the same risk factors of acquiring cervical cancer. So it's like, so just to answer your question again, is that it covers 6 and 11 and 16 and 18, which are the
So then if we look at it and apply, it's difficult sometimes to mix what people will call moral thinking with kind of religious persuasion with science, where we can see a direct correlation between the cause of a disease and the treatment for it. So then there is a case to be made for the vaccination of girls against HPV to rule out cervical cancer in the future. Is there not?
Yes, there is a case to be made because we have kind of a cause and effect relationship, cause and effect scenario. We know that cervical cancer is caused by HPV, and if you don't do something about it, especially if it persists, it's going to become cancerous. So it's a strong case for vaccination. However, we have experienced a lot of vaccination hesitancy because of course, we are very pious and
of course,
we listen a lot to our religious leaders, and we conform because of the fears. Their fears, for example, being that the vaccine will promote promiscuity and other issues.
Some of the campaigners against the vaccine are gynecologists and obstetricians.
I thought, I was really fearing you not to ask me that question.
Well, we have now removed the fear because we've actually asked the question. So there's nothing more to fear.
Eric, I don't know how to answer that because these are our colleagues, and of course we have to listen to everybody and their concerns, and so we have our own mechanisms of holding discussions in our technical working groups, in our annual scientific congresses, because we have to come to, not necessarily to a consensus, but to an agreement that it's important to have the vaccine.
Is it usually a scientific argument, or is it now a moral argument?
It could be both, because what the what's leading to vaccine hesitancy is concerns like that it will lead to what? Infertility, and that the women may not conceive or get babies, or when they get babies later on, they may have pregnancy wastage.
Are there research findings to substantiate such thinking?
None that I've come across. Yeah, none that I've come across. Yeah.
Are we therefore saying that when we look at the issue of the vaccine and the discussion around it, that young women who have sexual debut at a very young age then also run the risk of contracting the HPV virus and consequently are at risk of cervical cancer?
Yeah, that's a very good point you brought up. Maybe I forgot to mention it, in that early sexual debut is a risk factor, because during this time when they are adolescents is when the cervix is dividing and forming, and the cells are dividing very rapidly. And if one gets infected at that point, then the chances of transforming the cell are a little bit higher. Then there's also what we call the transformation zone on the cervix, where the infection tends to occur and cancers tend to occur. It's usually very active during the formative years, and so infection at that time also is quite risky in terms of persistence and also transforming cervical cancer later.
We have 30 seconds to go, but I see a question here that I think needs to come in, and you can answer in just 30 seconds. Is the HPV vaccine given to men and boys?
Yeah, it's a resource issue. Those who have eliminated cervical cancer in those countries give it to both boys and girls so as to achieve what we call herd immunity. Herd immunity means now the population is immunized. But if you're a resource constrained, you'd rather put it where you are going to get maximum benefit. And it's in girls, because they are the ones who have a cervix.
Okay.
Yeah.
Dr. Ari, thank you very much for joining us today. It's been very, very educative and informative. When you talk about cancer awareness, we've just been made aware. Cervical Cancer Awareness Month, that's the month of January, these 2 months of January, and that's why we had Dr. Elly Odongo joining us today for the Health Friday conversation. He's a gynecological oncologist. He is a former president of the Kenya Obstetrical and Gynaecological Society. Keep it here for more conversations.
This is The Situation Room, the only way to start your day.